Welcome back to the deep dive. Today, we are getting incredibly focused. We're diving into a stack of high-level clinical sources that detail the modern, very technical approach to chronic gastritis.
Yeah, and this is a topic that, it really does impact millions of people, but the actual critical distinctions, the things that determine life-changing interventions, they often get lost.
They get lost in these sort of generalized discussions about having an upset stomach.
Exactly. But this is a deep dive for the learner who needs that surgical precision.
Right.
We're not just talking about, a chronic upset stomach.
No.
We are unpacking current clinical guidelines. We're going to dissect some highly specific histological grading systems, the operative link on gastritis assessment or OLGA, and the OLGIM system.
And the focus squarely on prognosis, right? On the indicators.
That's the key. You are going to walk away from this understanding the monumental difference between, say, a relatively simple, highly treatable bacterial infection and a genuine, high-risk precancerous state that requires, well, lifelong surveillance.
That's really the mission for us today, isn't it? Moving past that basic diagnosis, gastritis, to understanding the really critical nuances of the treatment paths and, just as importantly, the mandatory surveillance recommendations that have to follow.
They have to follow.
Because as we're going to establish pretty early on, the difference between a stage I and a stage 4 diagnosis in this context is, it's literally the difference between taking a course of antibiotics and committing to aggressive periodic cancer monitoring for the rest of your life.
And that monitoring is absolutely essential because of the organism that is, well, the main driver of this condition worldwide. We hear about it all the time, the infamous bacterium Helicobacter pylori, H. pylori.
Right.
And we really need to explore when eradicating it works wonders and, crucially, the specific situations where eradication actually offers a very limited benefit.
But still done.
It is still done, and it's done primarily to mitigate future very severe complications down the line. It's a proactive measure, even when, some of the damage is already done.
Okay, so let's unpack that immediately. Let's start with what you call the cornerstone of management, targeting H. pylori. So looking through the sources in almost every clinical guideline, the message is it's universal and it's emphatic.
It really is.
Eradicating H. pylori is recommended for all patients when diagnostic testing shows any evidence of gastritis. It's the starting point. It's the foundation of the whole treatment plan.
Absolutely. It's step one.
What really stands out to me, though, is how broad the list of specific indications is. It's not just about stomach pain.
No, it's surprisingly broad, and that's because the bacterium's influence, it extends far beyond just the lining of the stomach. We need to detail these must-treat criteria because they cover a whole range of conditions. Some of them are systemic, even hematological, not just, localized stomach distress.
Okay, so let's start with the most obvious ones, the ones people probably expect.
Of course. So naturally, eradication is the initial treatment option for patients with dyspepsia. That's that persistent, bothersome indigestion who have a documented H. pylori infection. That's the classic case.
And peptic ulcer disease.
Oh, absolutely. It's clearly indicated for active or even past peptic ulcer disease. That is a clear-cut, indisputable case. We now know H. pylori is the primary cause of ulcers that aren't induced by medication.
Right. For decades, it was all about stress and spicy food.
Exactly. And now we know it's a bug.
But then we see these systemic connections that really underscore the bacterium's impact on the entire body. It's not just a gut issue at all.
Not at all. And this is fascinating. The therapy is clearly indicated for something called idiopathic thrombocytopenic purpura, or ITP.
Which is a blood disorder.
It's an autoimmune blood disorder characterized by a really low platelet count. And the link is incredible because the immune response triggered by the bacteria seems to cross-react with the patient's own platelets.
So it's a case of molecular mimicry, where the body's defense system gets confused and starts attacking itself.
Precisely. And we see a similar thing with another indication, unexplained iron deficiency anemia.
How does that work? How does a stomach bug cause anemia?
Well, the chronic inflammation and the changes in stomach acid caused by the infection can seriously impair iron absorption from food.
So even if you're eating iron-rich foods or taking supplements,
your body just can't absorb it properly, so you end up with this persistent anemia. Screening for and treating H. pylori in this context is a vital step in resolving the actual underlying cause of that anemia. It's not just about giving more iron pills.
And finally, there's a protective indication, one that's about preventing future problems related to other medications.
Yes, the source material really emphasizes the risk when long-term nonsteroidal anti-inflammatory drug, so NSAID treatment, is anticipated.
Things like ibuprofen or naproxen.
Exactly, especially if the patient already has a history of peptic ulcer disease. H. pylori and NSAIDs are just a severely damaging combination for the GI tract.
Let's elaborate on that a little bit, on that synergy, because it really helps explain why you'd treat the bacteria proactively, even if it's not causing symptoms yet.
It's like a two-pronged attack on the stomach lining. NSAIDs work by blocking protective compounds called prostaglandins.
And those are needed to maintain the stomach's defensive mucosal barrier.
Right. They essentially thin out that protective layer. Meanwhile, you have H. pylori releasing its own enzymes and toxins that directly attack the underlying cells and also prevent them from healing quickly.
Oh, so the NSAIDs are stripping away the defenses.
And H. pylori is actively burrowing into the newly exposed vulnerable tissue. So if you remove the bacterium, even if it's asymptomatic, you eliminate this massive cofactor for ulcer formation when NSAIDs are needed long-term for, say, arthritis or pain management.
That list provides just immediate clarity on who needs the treatment. But here's where we get into the deep end of nuance. We need to look at patients with functional dyspepsia.
Yeah.
The forces make a very careful distinction here about symptom relief versus long-term risk management.
They absolutely do, and it's a critical point. So functional dyspepsia is characterized by those persistent or recurrent symptoms of indigestion, bloating, feeling full really early, pain, but there's no obvious organic cause. You do an endoscopy and it looks normal.
And for these patients, what's the effect of the eradication therapy?
This is the key insight. For these patients, eradication therapy has only a limited impact on their immediate day-to-day symptom relief.
Wait, so they go through the antibiotic course.
And they might still feel bloated or uncomfortable the week after. The treatment might not fix their primary symptom.
That is a really critical point for managing patient expectations, isn't it?
Yeah.
Because if the patient isn't feeling immediately better, they're going to conclude the treatment failed.
Of course.
So why, knowing the immediate symptom relief is minimal, is the therapy still so strongly recommended? What's the trade-off?
The trade-off is the long-term cancer and ulcer risk reduction. And from a public health perspective, it is a massive victory. The therapy is still overwhelmingly advantageous because it eliminates the bacteria, and by doing that, it fundamentally mitigates the risk of developing peptic ulcer disease and, more importantly, gastric cancer later on in life.
So you're treating the future risk, not just the present symptoms.
Exactly. You are proactively eliminating the primary driver of decades of potential future damage, even if you haven't solved the underlying functional motility issue that might be causing their current discomfort.
That really illustrates this proactive long-game approach of modern clinical guidelines. It's about prioritizing long-term prevention over just short-term palliation.
It has to be.
But this idea of timing seems absolutely critical when we look at the efficacy of eradication versus the actual stage of the disease itself. The sources are so clear. The benefits are not uniform across the whole spectrum of chronic gastritis.
This is, I think, the single most important framework for you, the listener, to grasp. The protective effect of eradication is a moving target. It is completely dependent on how far the tissue damage has already progressed.
Okay, let's walk through that progression, stage by stage.
Let's start at the beginning. When we talk about non-atrophic chronic gastritis, that's the earliest stage where there hasn't been significant tissue loss. Just inflammation eradication is highly, highly recommended.
Why is it so effective then?
Because the tissue is still largely intact. It's responsive. If you remove the bacteria, the inflammation can subside entirely, promoting complete healing. This actively and aggressively reduces the person's lifetime risk of gastric cancer.
So we've caught the disease in time, we've removed the bacterial driver, and the stomach lining can generally recover its structure and function back to normal.
For the most part, yes.
But what happens when the disease has progressed a bit into the next stage, which is atrophic gastritis?
Once atrophy has set in, the situation changes quite a bit. Atrophy means the normal specialized glandular units in the stomach are starting to be reduced or lost. They're being replaced by essentially scar tissue.
And at that stage?
At this stage, the benefits of eradication start to diminish significantly. Treatment still offers some potential benefits. It might result in a partial regression of the gastritis, so a small number of glands might regenerate, or the chronic inflammation might lessen.
But it's not a full reversal.
No, the overall effectiveness and the extent of genuine tissue repair are much less compared to that earlier non-atrophic stage. The process of glandular regeneration is inherently slow, and it's often incomplete. The damage is starting to become permanent.
And then we get to the final stage, the one that feels like the ultimate clinical challenge, intestinal metaplasia.
Right.
And this is where the stomach tissue is actually morphed into something that resembles intestinal tissue. So what can eradication possibly achieve here, where the damage is so structural?
This is the most complex and clinically challenging stage, and the guidelines are very, very cautious. The literature confirms that eradication therapy does not reverse the metaplastic changes that have already occurred.
It doesn't reverse them at all.
Not at all. The change is a cellular structural transformation. The damaged cells are just gone, or they're functionally replaced by cells that shouldn't be in the stomach. The damage is, in effect, permanent at that point.
Okay, hold on. If the damage is permanent and the stomach tissue is always going to be changed, why bother treating the bacteria at all? Is it just a formality?
No, it is far from a formality, but the goal shifts entirely. We treat the bacteria because even though it doesn't reverse the metaplasia, the treatment can slow the progression to neoplasia.
So slow the progression to actual cancer.
To the development of actual precancerous or cancerous cells, yes. By removing the chronic inflammatory stimulus, the bacteria, you are essentially taking your foot off the accelerator of malignant transformation.
So we're just doing damage control. We're trying to slow the timeline, not reverse the damage itself.
Exactly, but here's the crucial distinction that feeds directly into our surveillance discussion later. Even if you slow the progression, the therapy does not reduce the overall significantly elevated risk of gastric cancer once metaplasia is established.
The patient is already in the high-risk group, period.
Correct. And that's why clinicians apply a cautious or, a weak recommendation for eradication in this context. It's necessary damage control, but it does not, under any circumstances, absolve that patient from the need for aggressive future surveillance.
That is a brilliant framework.
Yeah.
It really clarifies everything. The therapeutic value of H. pylori eradication is on a timeline. Maximum curative benefit at the earliest stages, diminishing but still relevant benefits at the atrophic stage, and a necessary but highly limited damage-controlling benefit once intestinal metaplasia has occurred. That timing defines the entire approach to chronic gastritis.
It really does.
Yeah.
Now, we have to shift gears completely. We've just established the gold standard for treating the infection. But what happens when that primary bacterial driver is absent? Or, even worse, the patient tests negative for H. pylori from the start, or they successfully complete the eradication therapy and their symptoms just persist.
Right. The bug is gone, but the pain is not.
Exactly. And this territory is clinically messy. It's messy because we lack a single targeted cause to go after.
I noticed that in the sources. The management of gastritis in patients who are H. pylori negative, it lacks standardized, definitive guidelines. There's a lot of clinical variability.
Right.
Why is there such a lack of standardization compared to H. pylori protocols, which are so clear?
It's because once you rule out the number one infectious agent, you are left in this vast clinical differential space. You could be dealing with autoimmune gastritis, maybe bile reflux from the intestine back into the stomach. It could be related to inflammatory bowel disease or a really complex idiopathic condition related to nerve or motility issues.
Or even just high levels of stress hormones.
Right. The cause becomes multifactorial, and that prevents a single, clean therapeutic guideline from being established. You can't have one treatment when you have 5 or 10 possible causes.
That makes perfect sense. And in the absence of a standardized causal treatment, clinical practice often reverts to empirical management, symptom-focused management.
Yes, exactly.
What's the most common immediate strategy in that case?
The most common and, frankly, the most evidence-based immediate strategy is the empirical use of proton-pump inhibitors, or PPIs.
So things like omeprazole or pantoprazole.
The very same. These medications are incredibly effective at significantly reducing gastric acid production, and they've demonstrated effectiveness in alleviating symptoms for many of these patients. They work by directly inhibiting the proton pumps in the parietal cells, which drastically lowers the overall acid burden on the already inflamed or perhaps hypersensitive mucosa.
So what are the specific guidelines around using PPIs in this scenario? I remember seeing there's a pretty clear age-based clinical cutoff.
Yes, there is, and it relates directly to cancer risk stratification. Current guidelines recommend empiric PPI therapy for individuals younger than 60 with dyspepsia if they test negative for H. pylori initially, or if they continue to experience persistent symptoms despite having already undergone successful eradication therapy.
And that age cutoff under 60, it feels like a critical safety mechanism. Because for older patients with new or persistent symptoms, a clinician can't afford to just mask the pain with a PPI, right? They need to investigate urgently.
Precisely. In older patients, the index of suspicion for malignancy is much, much higher. So the guidelines mandate an endoscopy and immediate investigation rather than just trying to treat the symptoms empirically with acid suppressants. But for that younger cohort, PPIs are a safe and effective first step.
But what if a patient is following that guideline? They're under 60, H. pylori negative, they're using PPIs, and they're still not finding relief.
Yeah.
What's the next clinical move into that sort of less supported therapeutic territory?
Well, the alternatives mentioned in the source material, they tend to target different functional components of the digestive tract. The main ones considered are prokinetic therapy or tricyclic antidepressants.
Okay, let's break down the mechanism of those two alternatives because they seem to reflect two very distinct hypotheses about what's actually causing the pain.
They do. Prokinetics are aimed at addressing potential motility issues. So the idea that the stomach is emptying too slowly, which leads to that feeling of early satiety or bloating, they help speed up the movement of food through the GI tract.
And the tricyclic antidepressants.
The tricyclics, on the other hand, are often used at very low doses, not for their antidepressant effect, but because they modulate visceral hypersensitivity.
What does that mean exactly?
They essentially calm the nerves that are lining the stomach. They reduce the sensitivity to stretch or to minor irritation that the patient is perceiving as pain or severe discomfort.
So it's almost like a targeted nerve blocker, just for the gut.
That's a great way to think about it. However, and this is vital to note, the source material includes a very important caution here. The supporting evidence for these alternative treatments is explicitly described as being low to moderate quality.
So clinicians are proceeding with these options, but they know they're moving into less well-supported and probably highly individualized therapeutic territory.
Exactly. It's a case-by-case basis at that point.
And this really highlights the main challenge here. Once H. pylori is ruled out, or the structural damage is permanent, the management moves from a very clear protocol to a much longer, more complex journey of trial and error.
It does. And for many of these patients, particularly those with atrophy, the goal shifts entirely away from just managing symptoms.
Right. It becomes pure risk assessment.
Absolutely. The focus immediately shifts from treating a specific bug or a symptom to managing the potential for an ongoing silent internal disaster, the progression to cancer.
And this section, I think, represents the moment in the medical timeline where the treatment goal just fundamentally changes. We established that eradication only partially helps at this stage, and now we confront a really chilling reality. Currently, there is no definitive curative treatment that exists for patients who are diagnosed with atrophic gastritis.
That realization that you cannot reverse the tissue loss with any known medication is pivotal. It means the entire focus of management shifts wholly to risk stratification.
It's all about risk.
All of it. The entire effort is now centered on assessing the precise severity of the disease and determining the immediate and long-term risk of gastric malignancies. We are now in the realm of mandatory surveillance, not cure.
And this is why the histological grading systems become the absolute essential tools for clinicians. They need a hard numeric roadmap to handle this risk. If you can't treat it, you have to measure it perfectly.
Precisely. You need quantifiable, standardized measures. And the two essential tools introduced in the sources, the ones that clinicians rely upon globally, are the operative link on gastritis assessment, OLGA, and the operative link on gastric intestinal metaplasia assessment, OLGIM grading systems.
And these systems are used to assign a stage, almost exactly like cancer staging, to the severity of these precancerous changes. So what is the severity threshold? What's the number that triggers serious action and mandatory surveillance?
The key takeaway here is the number. Staging gastritis using the OLGA and OLGIM systems with a stage 3 or 4 classification is associated with a significantly elevated risk of gastric cancer.
Stage 3 or 4.
That classification is the definitive cutoff point where generalized advice ends and aggressive endoscopic surveillance becomes an absolute necessity.
So stage 3 or 4 is the massive red flag that the pathologist is waving at the clinician. But why these systems specifically? What makes them so powerful compared to just a general description from a pathologist saying there's some atrophy?
They're powerful because they provide what the sources call an easily translated method for assessing attributable risk. This isn't just a subjective pathology report saying looks bad. It's a systematic standardized scoring that helps to remove observer bias. And these systems combine two key data points that are derived from the gastric biopsies.
And what are those two data points?
First, they use the detailed atrophy scores, which we'll break down in a minute, to measure how much tissue has actually been lost. And second, they factor in the topography.
Topography meaning where the atrophy is located across different sections of the stomach.
Exactly.
Wait, why does the location of the atrophy matter so much in predicting cancer risk? It's not just about the volume of damage.
No, it is not. The stomach has different specialized regions. The antrum, which is the bottom part connecting to the small intestine, and the corpus, which is the main body where most of the acid is produced.
And atrophy in one area is worse than the other.
It tells a different story. Atrophy that begins in the corpus is often associated with autoimmune gastritis and an extensive loss of those acid-producing parietal cells. Atrophy in the antrum is usually H. pylori driven and often involves a different cancer progression pathway. So the location and the extent of the atrophy define the risk field.
I see.
By combining the severity score and the topography, they can assign a robust clinical stage, which ensures standardization where there used to be a lot of variability. It helps the clinician understand the overall field effect of the damage.
That's fascinating. It's the combination of the severity and the location that determines the overall risk stage. This makes the next section, diving into the actual histology and the mechanics of the scoring, absolutely necessary.
Yeah.
We need to understand the precise numbers that define these grades.
Let's get technical. Let's put these precise numbers into context for you. Okay, so when a pathologist looks at a gastric biopsy, the very first job is to establish a baseline, defining what is considered normal tissue versus what constitutes active inflammation, which is, by definition, gastritis.
And the source material provides those wonderfully specific cell counts for what a normal baseline should look like.
It does. Think of a healthy stomach lining as a town where a small number of police are just perpetually patrolling. In normal gastric mucosa, an acceptable cellular range, that baseline patrol, is typically 2 to 5 lymphocytes, plasma cells, or macrophages per high power field, or HPF.
And a high power field is just the view under the microscope at high magnification.
Exactly. Or you might see 2 to 3 of those cells located between the foveolae, which are the small pits on the surface of the stomach lining. That's just the background noise of a healthy immune system maintaining order.
So gastritis is simply a quantifiable increase in this density. The patrol force has been substantially called up.
That's the perfect analogy. The degree of increase from those normal numbers determines the severity of the chronic inflammation, which is then graded on a 3-point scale. Mild, plus, moderate, plus, plus, or marked, plus, plus, plus. If you see a massive influx of those immune cells well above that 5-cell baseline, you are clearly looking at inflammation. This density measurement of chronic inflammatory cells is the fundamental starting point.
That seems straightforward enough, but you mentioned earlier that the pathologist has to be really careful about where they take the sample from, otherwise the count will be skewed.
That's the critical subtlety. There's an important caveat here. This density measurement must be performed away from any lymphoid follicles.
And why is that?
Because those follicles are localized areas of intense immune activity. They are often directly related to an underlying H. pylori infection, which creates a concentrated area of inflammation that would unfairly skew the overall grading of the general background mucosa. The pathologist has to grade the overall background inflammation, not just the localized response hotspot.
Got it. And we also noted a very specific form of inflammation of the sources, one with a unique name.
Yes, lymphocytic gastritis. It's defined specifically by a very high density of just one type of immune cell lymphocytes. It's defined as more than 25 lymphocytes observed per 100 epithelial cells within the glandular epithelium.
So when 1/4 of the cells in the lining have a lymphocyte sitting right next to them.
That signifies a very specific type of inflammation, which is often associated with things like celiac disease or certain drug reactions. It's a different pattern.
Okay, we've covered the general chronic inflammation. Now, how does the biopsy specifically measure the activity of the gastritis, meaning how destructive the inflammation is right now?
The activity is measured specifically by the density and critically the location of neutrophils. Neutrophils are the acute responders. They are the frontline infantry of the immune system.
The first on the scene.
The very first. And the grading of gastritis activity follows a similar 3-point scale, but it's based entirely on where these cells are seen. The location tells you how aggressive the current attack is.
So where are the three locations that define the mild, moderate, and marked activity?
Okay, if you only see neutrophils in the lamina propria, that's the connective tissue layer just beneath the surface epithelium, that indicates mild plus activity. They are, to use our analogy, hanging out in the streets, but they're not actively breaching the buildings.
In moderate.
If the neutrophils have moved into the epithelium itself, that denotes moderate plus plus activity. They are now infiltrating the cellular lining. They're breaking down the doors.
And finally, marked activity.
Finally, if the neutrophils are seen in the glandular lumen, meaning they are attacking the very structure of the glands themselves, that signifies marked plus 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 activity. They are inside the functional units, causing immediate active destruction. This gives the clinician a dynamic, acute sense of the disease.
That defines inflammation and activity. Now, for the truly prognostic aspect, the atrophy score, this is what defines the long-term cancer risk. So what is the precise pathological definition of atrophy?
Atrophy is defined as the discrepancy between the expected glands for the anatomical site and what is actually observed in the sample. It's characterized by a reduction or even a complete absence of the glandular units themselves.
So the functional parts of the stomach are just gone.
They're gone. And when these specialized glands, the ones that produce acid, mucus, intrinsic factor, are lost, the stomach lining often responds by laying down collagen, which results in fibrotic scarring in that lamina propria.
And this often involves metaplasia, which we said is a key part of the cancer progression pathway.
Correct. Metaplastic changes involve the replacement of those normal specialized glandular units with units that are either metaplastic, meaning they resemble tissue from a different, less specialized area, usually the small intestine and/or dysplastic units, which are frankly abnormal and precancerous.
So how does the pathologist translate that structural loss into the numerical score that feeds into the OLGA and OLGIM systems? We need to understand the percentage loss benchmarks.
It's a clear, simple, three-tiered scoring system based on percentage loss. Think of it as minor, significant, and severe. A score of 1 is allocated when a small percentage, so 1% to 30% loss of the glandular architecture or its metaplastic transformation occurs. This is minor damage, perhaps patchy.
And a score of 2.
A score of 2 is assigned for a more significant loss, ranging from 31% to 60%. This is highly concerning. And finally, a score 3 is designated when the loss exceeds 60% of the expected glandular units.
Wow. Score 3 is severe, meaning the tissue is functionally gone. More than 2/3 of the expected functional glands are missing.
It's a devastated landscape.
Now, let's connect these scores back to the two grading systems, OLGA and OLGIM, and understand how they differ clinically.
Right. So the OLGA staging system is the broader of the two. It uses all the information available. It categorizes gastritis into 5 stages, each associated with a progressively higher risk of cancer. And it determines this by taking that atrophy score, the percentage loss, and factoring in the topography where that loss is located. These scores are tallied up to determine the final OLGA stage.
And the OLGIM system is the highly specialized variation of that, correct?
Yes. The OLGIM staging system relies solely on intestinal metaplasia for its atrophy score. It essentially ignores simple glandular atrophy, that initial tissue loss, and focuses only on the more advanced tissue change, the metaplasia.
Why make that choice? I mean, if they're both trying to assess risk, what is the clinical trade-off for focusing only on metaplasia?
The benefit and the reason OLGIM was developed is to achieve enhanced inter-observer reproducibility.
Meaning different pathologists are more likely to agree.
Exactly. Intestinal metaplasia is a visually distinct and universally recognizable cellular change, which makes it much easier for different pathologists in different labs across different continents to agree on the score. It standardizes the reporting.
But hold on a minute. If the OLGIM system ignores simple glandular atrophy and only focuses on metaplasia just to make it easier for pathologists to agree, isn't that a potentially dangerous trade-off for the patient? Why would a clinician ever prefer reproducibility over sensitivity when we're talking about high cancer risk?
That is an excellent point, and it's actually a source of active debate in the field. You are absolutely correct. The OLGIM system results in a notable decrease in sensitivity for identifying high-risk patients who might have extensive simple atrophy but haven't developed metaplasia yet.
So it might miss some high-risk individuals.
It might. The reason clinicians still use it is for its clarity in large-scale studies and for standardized reporting. However, a responsible clinician must always consider the entire pathology report, including the simple atrophy, and often use the OLGA system as the primary risk stratification tool, reserving OLGIM for reinforcing the risk when metaplasia is already
No,
confirmed.
that's not it either.
It shouldn't be. The choice really highlights a tension in medicine between perfect standardization and complete risk detection for the individual.
That makes the process feel much more dynamic than just a simple checklist. Regardless of which system is used, though, we come back to that high-risk threshold. What is the clinical mandate for a stage 3 or AV patient, defined by whichever system is being used?
Since patients who are classified as OLGA stage 3 or 4V face a considerable, significantly elevated risk of developing gastric adenocarcinoma, regular surveillance endoscopy is strongly recommended for these individuals.
And the goal is simple, but life-saving.
It's just to enhance the chances of detecting gastric cancer in the early, highly treatable stages before it becomes invasive.
And the sources provide a specific recommendation on frequency from the American Gastroenterological Association, the AGA.
They do. The AGA recommends endoscopic surveillance every 3 years for these patients as a baseline. This is where the clinician commits to bringing that patient back for follow-up biopsies and visual checks again and again.
But the surveillance frequency isn't fixed solely by the OLGA stage, is it? A clinician have to factor in other elements to decide if they need to see that patient sooner than 3 years.
Oh, absolutely. The 3-year period is the starting point, but a clinician must fine-tune that based on cumulative risk factors. These would include a strong family history of gastric cancer, especially in first-degree relatives, residents in regions with a very high natural incidence of gastric cancer, a history of persistent H. pylori infection, even after treatment, smoking history, which is a known cancer cofactor, and relevant dietary factors like high salt intake or low fruit and vegetable consumption. All these factors serve to amplify the risk and often accelerate that surveillance schedule.
That is incredibly comprehensive. We've moved from diagnosing a bacterium to numerically grading the tissue damage, and now we understand the necessity of those detailed periodic biopsies. So what are the ultimate consequences of these progressive stages? Let's transition to the prognosis.
When we talk about prognosis, we have to recognize the vast variability that's inherent in just the term gastritis. The prognosis varies so significantly based on the type, the underlying cause, and the patient's characteristics. While many routine H. pylori cases can be effectively controlled, some have dire outcomes.
You mentioned specific acute cases earlier that have very poor outcomes if treatment is delayed.
Yes, we must not forget those. Acute gastritis secondary to ischemia, a loss of blood flow, or emphysematous gastritis, which involves gas-forming organisms inside the stomach wall, those can be rapidly fatal if the underlying cause isn't treated promptly. They're severe, life-threatening conditions.
But focusing back on chronic atrophic gastritis, the prognosis hinges entirely on the severity of that atrophy or metaplasia we just spent so much time discussing in the grading systems.
Entirely.
And the reason we spend so much time on OLGA staging is because of the associated malignancy risk. We need to put quantifiable numbers to that risk for the listener to really internalize. What are the cancer incidence rates we're talking about?
This is where the clinical stakes become the highest. For the general population of patients who are diagnosed with atrophic gastritis, studies report an annual incidence rate of gastric cancer at approximately 0.25% per person year.
Now, again, that number sounds small in isolation, but when you zoom out and look at that over a lifetime and you compare it to the baseline risk, it represents a significant elevation.
It represents a massive lifetime risk increase. And consider a particularly high-risk group, patients with autoimmune metaplastic atrophic gastritis. The incidence of gastric adenocarcinoma is reported to be around 14.2 cases per 1,000 person years in that cohort.
And what's the general population rate?
Now, contrast that with the general population, where the rate is a mere 0.073 cases per 1,000 person years.
That is an almost exponential difference, a critical, high-magnitude risk that absolutely necessitates of that 3-year surveillance protocol.
It's the entire justification for it.
And the severity of the atrophy is what dictates how amplified that risk truly is. The sources break down the relative risk, the RR, by the extent of the damage.
Absolutely. This is the direct application of that biopsy score we talked about. The pattern, the extent, and the severity of atrophy are scientifically the most critical predictive factors. While metaplasia is important, the sheer grading of atrophy matters most. For moderate atrophic gastritis, the relative risk of gastric cancer is 1.7% compared to a healthy population. However, if the patient has severe atrophic gastritis, that's score 3 we discussed, That risk jumps dramatically to a 4.9% relative risk.
A 4.9% relative risk for a specific type of cancer is comparable to some of the risks we associate with heavy lifestyle factors. That is a massive data point for a clinician.
It is.
And critically, the sources confirm that mild atrophic changes have no elevated risk compared to the general population.
Correct. The jump from moderate to severe atrophy is the absolute critical point that must be identified in that pathology report. It translates directly into the difference between elevated vigilance and mandatory lifelong aggressive surveillance.
Now, despite some conflicting geographic data, which is likely related to region-specific factors like diet, environment, genetics, the global consensus is that H. pylori eradication improves prognosis, even if it doesn't cure advanced atrophy. So how much improvement are we talking about in terms of cancer prevention?
A systematic review indicated a really substantial public health benefit, a 1/3 reduction in cancer risk following successful H. pylori eradication. Globally, that is an enormous impact.
But this leads us back to that crucial concept we touched on earlier, the point of no return phenomenon. It really defines the limits of this protective effect.
This is the scientific justification for early screening. The literature highlights that the maximal benefit is seen early. Studies show a reduced incidence of gastric cancer only in patients who were H. pylori carriers without precancerous lesions, so without established atrophic gastritis or gastrointestinal metaplasia.
So once those changes happen,
It strongly suggests that once those specific histological lesions develop, the protective benefits of merely eliminating the bacteria decrease. You've removed the driver, but the car is already severely damaged and is still moving toward the cliff edge. At that point, aggressive surveillance, not just eradication, becomes the new focus.
that makes the early identification of H. pylori even more critical, regardless of immediate symptoms. But cancer isn't the only malignancy associated with chronic gastritis, is it? We need to fully detail the lymphomas.
Yes, malt lymphoma is a significant and very specific complication. Extranodal marginal zone B-cell lymphoma, or malt lymphoma, is strongly associated with H. pylori-induced gastritis. There's even histological evidence suggesting that the lymphoma originates from B-cell clones that congregate at the very site where the chronic gastritis was previously sampled.
That sounds like a direct, undeniable link. What's the specific molecular mechanism that drives the B cells to become cancerous?
It involves a mechanism that is a truly fascinating example of bacterial manipulation of human cells. Molecular studies demonstrate the translocation of the bacterial protein KIGA, which is a specific virulence factor found in highly aggressive strains of H. pylori, directly into human B lymphoid cells.
So it injects this protein into our immune cells.
Yes, and this translocation activates specific cellular signaling pathways that crucially inhibit apoptosis or programmed cell death.
So the bacteria introduces a protein that acts like a cellular immortality switch for these B cells.
Essentially, yes. The B cells, which should naturally die off, survive longer and begin to proliferate uncontrollably. And that leads directly to the formation of the malt lymphoma.
What's the most compelling clinical evidence that links the two, that proves causality?
The most compelling evidence comes from clinical trials that have documented the complete regression of early-stage gastric B-cell lymphoma after successful eradication therapy alone.
You mean without chemotherapy?
Without traditional chemotherapy or radiation, you remove the bacterial trigger and the malignancy reverses itself. That is powerful, almost magical evidence of a direct, causal, and thankfully reversible relationship.
Incredible. Okay, moving on. What about gastric neuroendocrine tumors, or NETs?
NETs represent another known, though less common, complication of atrophic gastritis, particularly the autoimmune subtype. The chronic inflammation and the loss of acid production lead to elevated levels of the hormone gastrin.
And gastrin overstimulates.
It overstimulates the specialized and chromaffin-like, or ECL, cells in the stomach. And this constant overstimulation can result in the formation of these NETs.
And the prognosis here is contingent primarily on the tumor size, which again makes early detection so vital.
Absolutely. The prognosis is primarily determined by size, mitotic activity, and the extent of invasion. Importantly, small NETs, those less than 2 centimeters, can often be managed successfully with just an endoscopic resection, and they carry a very low risk of metastasis.
And what's the risk threshold for size?
Larger tumors, those that are over 2 centimeters, have been associated with a reported metastasis rate of nearly 20%. The size difference is prognostically vital, reinforcing, yet again, the need for that stringent surveillance. If we catch them when they're small, the patient is likely fine. If we catch them later, the risk profile changes drastically.
Finally, let's wrap up the systemic and hematological complications. We mentioned them as indications for treatment, but let's delve into the specific mechanisms of the deficiencies.
So, H. pylori-induced gastritis can lead to peptic ulcer disease, of course, but the biggest hematological consequences are immune thrombocytopenic purpura, iron deficiency anemia, and vitamin B12 deficiency.
So how does the damage to the stomach lining specifically cause anemia and B12 deficiency? Let's start with iron.
For iron deficiency anemia, the mechanism is twofold. First, you can get chronic, low-grade blood loss from the inflamed mucosa, though it's often very subtle. But more importantly, the inflammation and the subsequent loss of those acid-producing parietal cells severely impairs the absorption of dietary iron.
Because iron needs an acidic environment.
It needs an acidic environment to be processed and absorbed efficiently, and chronic gastritis completely compromises that environment.
And for vitamin B12 deficiency.
For vitamin B12, the link is even more direct and critical. B12 absorption requires the production of a specific protein called intrinsic factor,
Which is secreted by the same parietal cells that produce stomach acid.
Exactly. So as atrophic gastritis progresses and those parietal cells are destroyed and lost, intrinsic factor production just ceases. Without intrinsic factor, B12 cannot be absorbed in the small intestine, and that leads to neurological symptoms and megaloblastic anemia.
The sources highlight specific screening protocols for anemia and ITP now that this mechanism is so well established.
Yes, expert guidelines now advocate for screening and treating H. pylori in patients with recurrent or treatment-resistant iron deficiency anemia, provided their upper and lower endoscopies are otherwise normal and unexplained.
So, in cases of mysterious anemia,
Clinicians are directed to look for the bacterial link, and consensus guidelines for managing ITP similarly recommend screening for H. pylori in all adult patients with the condition because of the high potential for resolution just through eradication.
and lastly, there's that fascinating, although still preliminary, connection to metabolic health.
Yes, recent reports have indicated a potential association between H. pylori-induced gastritis and systemic conditions like insulin resistance, metabolic syndrome, and even non-alcoholic fatty liver disease, or NAFLD.
That sounds like the stomach infection is causing obesity or diabetes. What is the hypothesized mechanism there?
It's hypothesized to involve the chronic inflammatory state that the bacteria creates. H. pylori infection triggers a chronic, low-grade inflammation that doesn't just stay in the gut. It affects the whole body, potentially altering circulating levels of certain hormones like ghrelin and leptin, and leading to systemic insulin resistance.
But the sources were extremely cautious about declaring causality.
They were. The source material is very clear, and it stresses that there is insufficient evidence to establish a definitive causal link between gastritis and these metabolic conditions. It's an association that warrants intensive further study, but it is not yet a proven cause and effect relationship.
So we end this section with the certainty of cancer risk, lymphoma, and systemic deficiencies, but the uncertainty of a metabolic connection.
That's a good summary.
This has been a truly comprehensive deep dive into the world of chronic gastritis. We started with a simple, ubiquitous bacterium, and we finished with the complexities of cancer risk assessment and molecular pathology. The core insight for me is really understanding the spectrum, from simple H. pylori infection, which is highly treatable with maximal curative benefit, to the irreversible tissue damage of severe atrophic changes and metaplasia.
We've established that once that tissue loss occurs, the focus shifts entirely to rigorous risk stratification via those sophisticated OLGA and OLGIM stages, which then demands mandatory surveillance, every 3 years for stage 3 and 5E patients. We saw how critical the pathologist's report is, defining normal histology down to 2 to 5 cells per high-power field, grading inflammation activity, and quantifying atrophy based on percentage loss to create a truly actionable risk stage.
Before we wrap up, I think it's crucial to give context to you, the listener, about why an initial diagnosis of gastritis is often so difficult for a clinician. The symptoms, the dyspepsia, pain, discomfort, are incredibly nonspecific. They can mimic a dizzying array of other, often more serious conditions. The differential diagnosis is just extremely broad.
It is, and this reinforces the necessity of the diagnostic endoscopy and biopsy. The clinical symptoms of gastritis can mimic severe conditions like functional dyspepsia, peptic ulcer disease, gastric cancer itself, gallbladder inflammation or cholecystitis, rare acid hypersecretion syndromes like Zollinger-Ellison syndrome, pancreatitis, even serious cardiac issues like myocardial ischemia. The pain can be referred to the upper abdomen.
And we also have gastric lymphoma, celiac disease, and Multiple endocrine neoplasias all presenting with these overlapping symptoms of pain and indigestion. The deep dive into the actual tissue is not optional. It's the only way to rule out or identify these life-altering conditions and commit the patient to the correct treatment path.
And this brings us to our final provocative thought. We spent a lot of time detailing the point of no return phenomenon, where treating H. pylori is only truly effective in preventing cancer if it's done before those irreversible precancerous lesions like atrophic gastritis set in.
And we established that successful eradication reduces cancer risk by 1/3 overall, which is a huge number.
It is.
So, given that the maximal protective benefit is achieved before any precancerous lesions develop, what stands out is this question. Should screening for H. pylori be implemented even earlier? Perhaps, regardless of symptoms, as a general population health measure, similar to how we screen for HPV to ensure we catch every single carrier before that point of no return is reached.
It's the ultimate public health challenge, isn't it? When you're dealing with a bacterium that's both ubiquitous and definitively carcinogenic.
A question that must weigh heavily on every gastroenterologist and public health official.
If early identification is the cure, then perhaps widespread preventative screening is the necessary, though very challenging, answer.
We hope you walk away feeling thoroughly informed and perhaps a little more appreciative of the pathologist's precise counting under the microscope. Thank you for joining us on this deep dive.
We'll see you next time.